Hello and welcome to Williams Mullins Benefits Companion, a podcast that helps employers navigate the complex legal challenges of managing their employee benefit plans. I'm your host, Brydon DeWitt, and today I'm delighted to be joined by a new guest to our podcast, Caroline Susie, principal at MercerWELL. Welcome to the Benefits Companion, Caroline.
Thanks for having me.
Well, Caroline, when we were talking about doing this podcast, one of the hot topics for employers is offering GLP-1 medication in their group health plans. And I know there's, a lot of publicity about these medications and their uses and a demand by employees to have access to them through their group health plans. So let's kind of just start at the beginning. I mean, what are GLP-1s and how do they work?
Yeah, you can't watch TV for 5 minutes without seeing an advertisement for these, right? And everyone's so happy in all their commercials.
Right. Are these miracle drugs
yeah,
for weight loss?
100%. They are game changers for obesity treatment. Like, as a clinician, I'm a registered dietitian by background, like very excited about these medications. But yeah, what are they? So GLP-1 stands for glucagon-like peptide 1 agonist. And basically, it's a class of drugs primarily indicated for the treatment of type 2 diabetes and obesity, because what they do is they increase insulin release, the release of insulin to help get sugar out of your bloodstream into the cell so it can do its thing, delays digestion, and decreases your appetite. So right now, we know that they are really primarily indicated for those two, but we know every day there's a new indication, whether it's something around cardiovascular disease, et cetera. So I joke all the time that, you get a news alert every day and there's a new indicator. So employers are going to have to talk about this sooner rather than later because there's so many things coming down the pipeline. But really how they work is they decrease your appetite, they increase your fullness, they increase insulin sensitivity and insulin production, which helps increase the sugar uptake from your blood. And the type of drugs that we're talking about are like the Ozempic, Victoza, Wegovy, Saxenda, those types of medications.
Okay, all well-known brand names.
Yep.
Are they prescribed primarily? I mean, is it that they're prescribed for diabetes, or would it only be prescribed for someone with diabetes and obesity?
So what's interesting is the indicator for diabetes has been approved for over a decade. So they really aren't new medications. It's the weight loss indicator that is relatively new. So Ozempic and Wegovy are actually the same active ingredient. One's marketed for diabetes, Ozempic, and one's marketed for weight loss, Wegovy. So it's just different amounts of the same active ingredient. So really interesting. But I think it's important to note that we do have more research on how they're impacting patients living with diabetes. We are still very much in the early stages of learning how these drugs impact long-term patients living with obesity.
What makes this intervention, using a GLP-1, such a big deal as compared to other types of weight loss interventions?
I mean, I feel like we live in a society and culture that we don't want it now. We want it yesterday, right? Like instant gratification. And when we think weight loss interventions, historically, they've just been a little bit slower. So you have your traditional diet and exercise programs. This is maybe where you're working with a registered licensed dietitian. The average weight loss at the 1-year mark is anywhere between 0 to 5%. So not exciting, but honestly, even 2.5% reduction in body weight is still clinically significant for a patient living with PCOS, maybe trying to start a family. It can make an impact on your lipid panel. So while it's not like super exciting weight loss, it's still clinically meaningful. We have diabetes prevention programs. A lot of employers have something like this in place. It's a CDC curriculum that you follow. You have to qualify for this. Usually at the 1-year mark, the reduction in body weight is between 5 and 7%. So very exciting. But then you start looking at some pharmaceutical intervention. And there are other anti-obesity medications on the market. They just don't yield as significant weight loss. So we see anywhere between 3 and 5% with some of these Contrave and things like that. The GLP-1s, though, shaking it up. 15%, even over 20% reduction in body weight. Yeah. And so, I mean, that's just a game changer for somebody living with class 3 obesity. And don't forget bariatric surgery. I feel like people still forget this. Bariatric surgery is still the gold standard for treating class 3 obesity when you think long-term weight loss. So at the 7-year mark, patients that have had bariatric surgery are still seeing about 20% reduction in body weight and maintaining that. So it still absolutely serves a place when we think weight loss intervention. But yeah, when you look at that 0 to 5% or 5 to 7%, and then the GLP-1 is, 15 or north of 20%, the people are intrigued.
Yeah, I mean, this is interesting. I mean, employers for a long time now have been focused on wellness programs that try to meet certain biometric thresholds and weight loss and offering Weight Watchers at work.
Mhm.
And so, I mean, why is that? Why are employers focused on weight loss?
I mean, I think part of that is market demand. You kind of said that when we started the podcast, is that the people want this. Our society just puts such an emphasis on living in a smaller body when in reality you can be living in a smaller body and still have significant health risks. I'm sure people listening to this podcast, when you look at your high cost claimant report, you're going to have people that are living with cancer, that oncology patient that again might be living in a smaller body. It doesn't have anything to do with weight. But we do know, we do have research that members who are overweight or living with obesity definitely have additional weight related comorbidities. So we see things like sleep apnea, we see association with other cardiovascular diseases like stroke, hypertension, or coronary artery disease, musculoskeletal issues. I mean, MSK is always a top spin in top conditions. So chronic back pain, knee or other joint pain, arthritis and gout, type 2 diabetes and prediabetes. And then don't forget mental health. Behavioral health is still a top concern of employers, and patients who are living overweight or living with obesity are seeing more depression and anxiety. We also know that when there is a reduction in weight, it can lead to annual healthcare savings. And I know you're an attorney. I'm going to make my joke, not to sound like an attorney, but it depends. It depends that range because it depends on how much weight is lost and, of course, the relevant comorbidities of that member. But it can be anywhere on average between 500 and over 5,000 annually with weight reduction. So, we want employees to live longer. We want them to live happy, healthy lives. We want them to thrive at work and thrive at home. So how can we think of that member holistically and not be hyper focused on weight per se, but what can we do regardless of the size body they're living in, help them achieve that their healthiest version of themselves?
Yeah, I mean, it makes sense just from a dollars and cents perspective that if you can get your participants to lose weight, then that is going to prevent all of the expenses of treating heart disease and cancer and
And like
diabetes.
maintaining it. I think that's
Right,
the other big
right.
thing. Like it's
It's
not just
maintaining.
losing the weight, it's really how can we tee the patient up for long-term success to maintain it? Because the last thing we want is for an employee to have that emotional roller coaster of we've all been there. We know weight is challenging, behavior change is hard, and weight loss is cyclical. But we don't want somebody to do something or be on this medication and then discontinue it for whatever reason after 3 months or 4 months, and then all the weight comes back on. That's a terrible member experience. I mean, can you imagine how frustrating it would be for that member? And obviously, when you think about the plan sponsor, like the employer just shelled out a couple, 3, 4,000 plus dollars. And for what? The outcome isn't there. So I think you really have to be thoughtful in your weight management strategy and how you're supporting members regardless of the size body they're living in.
That's interesting. So if you're an employer thinking, well, we're gonna cover the cost of GLP-1s, and the goal was to have employees lose weight and be healthier and reduce our costs, but you don't have a corresponding wellness program, perhaps to support someone, to the folks who lose weight to help them manage their weight and keep it off when they go off of the Ozempic or the Wegovy. You've really, just from an economic standpoint, you've wasted that money, right? Unless you provide
Yeah,
support to help. If that's the goal, if the goal is we want to help everyone lose weight, be happier, more productive, have lower health costs, fewer health problems. I could see that the GLP-1s are a part of that, but they're not the total solution.
absolutely. And I think that when you think of your total, cardiometabolic strategy or weight management strategy, there's going to be programs for, again, regardless of the size body you're living in, but particularly for your patients that are members that are taking these medications, you got to have a game plan, right? And so when we think what our best practices for holistic member management, a few things jump out. So I think consistency across benefits. So determining if coverage or exclusion of weight loss medication and services is consistent across all health benefits. So if covered, provide a GLP-1 option for the highest risk group to align with your bariatric coverage, right? Strong PA requirements. I mean, prior authorization is just a no-brainer here.
Right.
Providing coverage based on PA criteria, review the efficacy at every prescription renewal, whether that's 3 months or 6 months. Formulary management, get your pharmacy team involved to make sure that we're managing formularies, placing generic weight loss medications, perhaps in tier 1, brand names maybe in higher tiers to help drive utilization. But I think what we're really seeing for employers that are choosing to cover GLP-1s for weight loss is this whole person view. We know these medications are meant to be prescribed in conjunction with lifestyle modifications. And I think a lot of people think lifestyle modifications and they think a health coach with their measuring cups telling you, okay, right, and measure your half a cup of oatmeal at breakfast. That's not what we're talking about here. We want to make sure that these patients have access to a clinician, a registered dietitian in most cases is what we're seeing, to provide medical nutrition therapy to ensure that these patients are not going to be deficient in any vitamins and minerals. We can mitigate side effects early. We can make sure they're hitting their protein goals and hitting their fiber goals, because this weight loss is rapid and it's really challenging when the patient isn't hungry, right? So making sure that we're providing access to the appropriate clinicians, that behavioral health support is key, so that, again, the patient is safely losing this weight and we're teeing them up for long-term success. But as you can imagine, this vendor space, it is wild. It is wild. I feel like every day there's somebody new. So we really encourage our clients to have discussions around vendor accountability. What do performance guarantees look like? What does the prescribing trends look like if this vendor will be prescribing to you? What can you tell us beyond weight loss? Like, obviously we're losing weight. That's like the whole outcome of GLP-1s. What else can you tell me on how this patient is improving? Who is getting this medication? Were they high risk before and now lower? We've improved in the risk stratification. What milestones can you share? Really holding your vendor partner accountable, because this is an expensive investment. You have the drug, you're going to have the vendor costs. So, I mean, you really want to make sure the juice is worth the squeeze and you're getting the outcomes that you expect.
So this all makes a lot of sense, right? But I know that employers, when they look at covering GLP-1s, a threshold issue is just the expense. These are very expensive drugs. So what do you see employers doing? Are they covering these drugs? Are they moving to provide coverage?
Yeah, I mean, this is balancing empathy with economics, right? Not a fun decision to be had. I think because these drugs are so expensive, we tend to see the larger the size client, the more likely they are to cover. So about 50% of our clients are covering for weight loss today. But again, the larger size of the employer, the more likely they are to cover.
Are there ways that employers can mitigate the cost?
There's a lot of vendors in the space promising a lot of things. Some of the emerging practices we're seeing, again, I know we spent a minute talking about prior authorizations, but those PA requirements are something that is very, I feel like, table scapes at this point if you are covering. There's a lot of conversations too about increasing the BMI thresholds. We see some health plans doing this right now. The FDA indicators are a BMI, body mass index, of 30 or greater, or 27 with other comorbid conditions. So potentially increasing this, requiring some of that participation into working with a dietitian, either nutrition coaching or having that kind of support alongside. Anytime you require anything, I'm sure red flags are going up for you. There's always compliance considerations. So things to think about. We have some clients that want to essentially think bariatric surgery in the 2000s. They want to require people to do 90 days of intensive lifestyle intervention with a dietitian prior to getting the medication, or step therapy. We want documentation that you tried working with a dietitian, you tried other anti-obesity medications on the market, and you were not successful. Okay, now it's time for this medication. I think also limiting the pool of prescribers. We have very few clients that do this because it can feel disruptive, but gosh, it is effective, where the only way to get this medication is to go through this vendor. So this vendor will be our prescribing provider, all the prescribing providers, and they have the care team all within this solution. So it is a bit disruptive, as you can imagine, but we do have a few clients that are taking a little more progressive approach on it. And the outcomes have been very exciting because you do limit the pool of prescribers. It's not just a free for all. I shouldn't be able to go, get my Botox to get this prescription, but for better or worse, that's sometimes what we're seeing out when I say GLP-1 prescribing in the wild.
So I think we've kind of just, my next question, we've kind of discussed this. If an employer is thinking about including GLP-1 in their covered medications under their plan, the things that they need to consider, I guess, are to have a more comprehensive wellness program to wrap around
Yep.
the GLP coverage. I mean, is there anything
Yep.
else that employers that are thinking about adding coverage?
You're right. We talked a lot about the support from the weight management side of the house. And again, that nutrition counseling from a registered licensed dietitian. I think the other thing that's very important is that you also are addressing social determinants of health. You never want to assume that everybody has access to food or how many mouths that paycheck is feeding. So ensuring that there's a screening in place for social determinants of health, that if you do identify a population with certain needs or barrier, that's going to be built into your overall strategy. And then I know I mentioned mental health support. I want to say it again. It's just so important. It's absolutely a part of the strategy. So making sure that you have a partner that's using clinically validated screenings at baseline and follow-up touch points just to make sure that patients are supported and that the vendor is using motivational interviewing techniques to help members understand and, of course, yield behavior change. But those are going to be probably the big areas that we'd want employers to think around best practice guidelines and considerations when building out your strategy and thinking about partnering up with a vendor.
Well, Caroline, thank you so much for coming on to the Benefits Companion. This has been very informative and interesting.
My pleasure. It was a delight. Thank you for having me.
So that'll wrap up this episode of the Benefits Companion. If listeners have any questions or suggestions for future episodes, please contact me. You can also visit our employee benefits page at williamsmullen.com/employee benefits. There you can find out more about our team, as well as past episodes of this podcast and legal alerts. Finally, be sure to subscribe to this podcast to be notified when our next episode posts. Thanks for listening.
This podcast contains general condensed summaries of actual legal matters, statutes, and opinions for information purposes. It is not meant to be and should not be construed as legal advice. Individuals with particular needs on specific issues should retain our services or the services of other competent counsel.